So welcome back to the Amazing Newborn, everybody. We're going to go ahead and get started. So, of course, because of technical difficulties, the first part of Martha's Muller's presentation is recorded, and she'll go ahead and do the last 10 minutes from home. She has a cold. Her kids brought home a cold to her and to the whole family earlier this week, and so they're all at home coughing. She said that she was very happy that they don't have COVID, but still everybody's sick. So hopefully she'll be able to get through the last 10 minutes. It'll be a little glitchy at the end. That's just kind of one of the things that we're having to deal with. So our first speaker today is Dr. Martha Muller. She's one of my favorite people. She's just one of those physicians that you can just go ahead and stop in the hallway and ask whatever silly question you have. She is the liaison for the UNM Infection Prevention and Control Department right now. She was promoted to the Children's Hospital's epidemiologist, which, blew up into a really gigantic job a little while ago, and the Pediatric Antimicrobial Stewardship Medical Director. She has worked diligently to develop and implement appropriate pediatric infection control policies throughout our hospital. We see her everywhere, and she does play an instrumental part in the quality improvement with the Department of Pediatrics as it relates to hospital-acquired infections, which we hear a lot about in our jobs. She helped develop policies such as utilization of prophylactic ethanol locks in pediatric gerontology. I can never say that word right. With CVL lines. Her work on this committee is a foundation as the Visent Pediatric Scoreboard Developmental Committee forges ahead with a goal to develop a quality-based scoreboard specifically geared for the comparisons of quality efforts in and for pediatric patients. She has taken an integral role in the UNM Children's Hospital COVID-19 response, sorry for mentioning that, ensuring patients receive necessary interventions and care during the pandemic. So we're going to go ahead and start Martha's presentation. Like I said, if you guys have any questions, let us know. We'll be looking at the chat box. And towards the end, the last 10 minutes or so, she's going to go ahead and pop on and give the last part of the presentation herself. So thank you, guys.
Good morning. I am honored to spend a little bit of time with you this morning to talk a little bit about congenital syphilis, something that is near and dear to my heart and to the hearts of many of us at the University of New Mexico. I have no disclosures to report for this presentation. And when I consider this quote from Sir William Osler, "He who knows syphilis knows medicine," as well as this designation that is often ascribed to syphilis as the great masquerader, I really think about how true that is. Syphilis is an infection that has this uncanny ability really to often escape the differential diagnoses of providers as it wreaks havoc on its patients. It's one that we often have to really stop and consider intentionally when we have patients who are presenting with this particular infection. Now, syphilis is a disease that has been around for a while, okay? Initially reported in 1494, early names included things like the Great Pox, Lues venereum, Morbus gallicus, and it also has the distinct honor, if we would call it that, of being the first recognized sexually transmitted infection. And back in the day, was no respecter of social status when it came to flexing its disease-causing muscle. It really was a disease that affected many people. And unfortunately, That history includes congenital syphilis. Its recognition has been just about as long as the recognition of syphilis as a whole. This description, I love this description provided very early, and as early as 1497. This is shown too in the children of an infected father or mother. I have seen a boy born with the whole body covered with the pustules of the Italian disease. So congenital syphilis has been here, and there's certainly no new kid on the block. So fast forward to modern day, and we are still seeing the effects of this disease in its full might. This data is from the CDC, and it demonstrates that more recently, primary and secondary cases of disease in women of childbearing age have been on the rise. And we can see here that congenital syphilis cases have also followed that same trend. Thus, one can see that as a neonatologist, as a pediatrician, it's also very important for us to keep a pulse on this disease in women of childbearing age to help guide what we may see happening in our infants. As we move a little bit closer to home, this data also reported by the CDC showed that in 2019 in New Mexico, at almost 118 cases per 100,000 live births, our state epidemiology boasted some of the highest reported rates of congenital syphilis in the nation. With that epidemiology in mind and as a backdrop, let's consider this case. We have a 20-day-old term infant male who was transferred from an outside hospital for fever, rash, and thrombocytopenia. He also had a rash that was described as red circles, which were dry in the middle, that started on his hands and arms and spared his trunk. He had been seen by his primary care provider and by an outside emergency department for evaluation, and his family was provided anticipatory guidance. On the morning of his ultimate admission at the University of New Mexico, he was noted to be febrile and also had some associated irritability. And prior to his ultimate transfer, he was designated as having perioral cyanosis with multiple episodes of apnea and desaturation. Upon his admission and evaluation, his labs were notable for a serum pleocytosis with a neutrophilic predominance, some anemia, a thrombocytopenia, and evidence of inflammation with elevated CRP. And on physical examination, what was most notable really was his skin. He didn't have a significant rash throughout his body, but he did have some small lesions on his lower extremities that were copper colored and in varying sizes. He had a left groin area lesion with one small erythematous macule, and he had one small copper colored lesion that was now desquamating on the back of his right thigh. Additional exposure history included mom endorsing having a rash of unclear etiology that occurred when she was pregnant that resolved on its own. This is a picture of the rash that little one had. Now, the truth of the matter is congenital syphilis is a preventable disease. Let's let that sink in a bit. This is a preventable disease, making the urgency for appropriate management that much greater. Congenital syphilis really occurs as a product of a lack of prenatal care and misscreening opportunities. This is further complicated by inappropriate maternal treatment and/or maternal reinfection. Risk factors include minimal prenatal visits, living in rural residences, a loss of previous pregnancies, an unknown duration of maternal disease, a third trimester treatment, so treatment that's kind of occurring later in her gestational course, high non-treponemal titers at the time of her diagnosis, and younger infant gestational age at the time of maternal diagnosis. All of these things are helpful for us to know and really let us start to have a foundation for beginning quality improvement to help diagnose and treat mothers appropriately. And when we are considering missed prevention opportunities, it's good to have a little bit of backdrop about what those opportunities are. This data from 2020 CDC MMWR over the course of a few years evaluated missed opportunities for preventing congenital syphilis in the United States. And as we can see, in 2019, no adequate maternal treatment despite receipt of timely syphilis diagnosis, and no timely prenatal care and no timely syphilis testing really kind of led the pack as far as the missed opportunities that were noted. Specifically in the West, which is getting to us in our neck of the woods, a lack of timely prenatal care was the most commonly missed prevention opportunity at a little over 40%, followed by a lack of adequate maternal treatment despite timely diagnosis at almost 29%. So we have a sense here of where we may start to put our efforts in helping to prevent cases of congenital syphilis. From a more practical sense in the world of pediatrics, why do we even care? Well, we care because diagnosing and appropriately treating congenital syphilis will prevent the devastating long-term chronic musculoskeletal, cardiac, dental, and neurologic outcomes from this infection. And unfortunately, if the infant that was presented a couple of slides ago, in the case was not properly diagnosed and treated, the devastating effects of late congenital syphilis could be expected in that infant. The likelihood of actual transmission from mama to baby is influenced by the maternal disease stage. Here we can see if mama is diagnosed with primary or secondary syphilis, we have a much higher likelihood than if mom has latent syphilis. Although it is reasonable here to note that it's not a 0% likelihood of transmission, even in later stages of disease. Certainly, syphilis can occur, congenital syphilis can occur at the time of delivery, so exposure at the time of delivery. However, most of our cases occur in utero. Interesting studies have demonstrated organism recovery in placenta and umbilical cord samples as early as 9 to 10 weeks of gestation. So most of what we are going to see happens from in utero exposure. Let's transition and think about what we may see as it relates to congenital syphilis. How do these babies tend to present from us? So when we think about congenital syphilis, we really have two distinct disease courses: early disease that occurs prior to 2 years of age, and then late disease that occurs after 2 years of age. And certainly this infection results in morbidity such as prematurity. So we may see kiddos who are born premature. It's even causative, unfortunately, of mortality, with a sobering designation as the second most common cause of preventable stillbirths worldwide. However, as is noted in this data from the CDC from 2015 to 2019, most of the infants born alive with congenital syphilis will lack many signs or symptoms. So they are asymptomatic kiddos most of the time. Now, of note, it's really important to realize that these infants may develop symptoms within 3 to 8 weeks later. This ultimately influences our overall management plan as providers. In those infants who actually demonstrate symptoms in early syphilis, rash, fever, and hepatosplenomegaly are common findings. Similarly, leukocytosis, anemia, thrombocytopenia are common laboratory manifestations. And when affected, which is reported in over 95% or so of symptomatic infants and 25% or so of asymptomatic infants with congenital syphilis, radiographic abnormalities include such findings as diaphyseal periostitis or metaphyseal osteochondritis. Now, central nervous system involvement also deserves a bit of an honorable mention, with cerebrospinal fluid derangements reported in greater than 50% of symptomatic and 10% of asymptomatic infants with congenital syphilis. And as many of you who have likely provided care for kiddos who need evaluation for congenital syphilis, we can see that these findings shape the ultimate evaluation performed for infants suspected of having congenital syphilis. Considering a little more closely the rash manifestations, as it's noted, cutaneous involvement is very common in early disease. A great proportion of these will be those maculopapular lesions. If we consider back to our case, this kiddo did have macular lesions. They're small, erythematous to copper in color, like our infant had. Sometimes we can see desquamation. Here we can see a picture of pemphigus syphiliticus, which is vesiculobullous in its nature. And it's important to note that the lesions are contagious. So this rash is a contagious rash. They also may have associated rhinitis, and that is also contagious as well. Lest we get a little comfortable and forget that these rashes can be contagious, I have to sneak in a little infection prevention and control. This is a beautiful study from 1952, actually, that surveyed dermatologists regarding professional dermatoses, and they had an unexpected finding in their physicians. So they had 125 dermatologists that were sent the surveys. 32 reported 51 cases of extragenital chancres caused by syphilis. And so this is a beautiful study that demonstrates the infectivity of these lesions and underscores the fact that contact precautions are vital for infants with skin lesions for which there is a concern for syphilis. Okay, I will remove my infection prevention and control hat and return to talking about congenital syphilis. So let's switch gears and spend a little bit of time talking about actual diagnosis. The organism is one that certainly definitive diagnosis, as with other infectious agents, revolves around identifying the organism proper. In the case of syphilis, this is going to be with procedures such as dark field microscopy and PCR. However, most clinical areas do not have the capacity to do this. Thus, the mainstay for diagnosing congenital syphilis really is based on serologic testing and a two-step testing regime. And this uses non-treponemal and specific treponemal testing. And it can be, you know, many labs will use the non-treponemal as screening and then confirm it with specific treponemal testing. And then other institutions like our institution will start with specific treponemal testing and follow up with non-treponemal testing. At any rate, whichever way the testing occurs, combining the two types of tests improves the accuracy of the diagnosis, giving the ability to know false positive non-treponemal tests with other medical conditions and the potential lifetime positivity of specific treponemal testing. It is important to note that we would want to obtain the same non-treponemal testing on both mother and infant so that direct comparison may be undertaken. And here we see that the non-treponemal testing, which is non-specific, includes the rapid plasmin reagent, RPR, and the Venereal Disease Research Laboratory, the VDRL. And then we have several different specific treponemal tests that we can use to look for the presence of syphilis antibodies specifically. Infant evaluation is key. It includes doing a fantastic infant physical examination, as we could see back with our case and with the table demonstrating the characteristics of early syphilis. Skin findings are going to be very important to see. Hepatosplenomegaly may be there. So the infant physical examination is very valuable. A CBC with differential, we noted anemia as a commonly seen laboratory derangement. Cerebral spinal fluid evaluation, especially looking for cell count, protein, and a quantitative VDRL. And then other tests as is clinically indicated. If the infant, for instance, has pulmonary symptoms, then we might want to get a chest x-ray. Often we include ophthalmologic evaluations, liver function testing, especially in the setting of hepatosplenomegaly, where we may see elevation of the liver enzymes, hearing evaluation, and long bone imaging as part of our routine evaluation for the potential of congenital syphilis. Now, obtaining an evaluation and then deciphering how to assimilate and interpret all of the appropriate data can evoke numerous emotions all at the same time. And it often leads our providers with a nice, what in the world are we supposed to do with all of this information once things are completed, once we actually have that information. The American Academy of Pediatrics Red Book has a super helpful algorithm which helps determine the best course of treatment for the infant. Now, it's important for us to know that maternal history is very important. It plays a very key role in helping us place infants in appropriate categories, as well as appropriately evaluating the infant. So it's a combined maternal and infant history and evaluation that goes into placing these kiddos into an appropriate category, which then would drive their appropriate treatment course. These categories designated by the American Academy of Pediatrics Red Book: proven or highly probable congenital syphilis, possible congenital syphilis less likely, and congenital syphilis unlikely. So we'll spend a few minutes just looking through various scenarios that may be commonly seen with some of your infants. Of course, we are often taking many of these infants on a case-by-case basis because some of the information available doesn't put them neatly into a box, but many of them can fit into these categories fairly well. So proven or highly probable congenital syphilis. Let's look at the first scenario for
Good morning, everyone. Thank you so much. I am so sorry. I'm not sure what happened with the audio. So I am here live just to speak with everybody and finish the rest of the talk. I will start by apologizing. I have managed to catch something and am having some respiratory difficulties here. So it will be a quicker dive through, but we will make it through. So here with proven or highly probable congenital syphilis, these are probably scenario 1 and scenario 2 are the ones I would think that from a provider standpoint, we tend to see the most frequently. So the first one is a situation where essentially mom did not have appropriate treatment. So her TPAB or like her specific treponemal antibody and her non-specific treponemal titers are both reactive, and she had inadequate treatment, whether that is no treatment at all. She did not receive penicillin, so we will talk in a couple of slides about treatment, and penicillin is the treatment of choice. Even if mom is allergic, we would have her desensitized if the treatment wasn't given in the appropriate time frame, so greater than 4 weeks prior to the infant being born. And even it's important to note that inadequate treatment includes undocumented treatment. It's one of the questions that we get very frequently as ID providers well, mom said she was treated, but we don't have that documented. And we would want to ensure that we had documentation so that we could confirm maternal treatment. So that is also included in inadequate treatment. Or mom has concerns for a potential relapse of her infection or reinfection, or her partner had a recent syphilis diagnosis. And when we combine that with an abnormal infant examination or an abnormal or incomplete evaluation for the infant, or the non-treponemal titers for the baby are at least 4-fold greater than maternals, that increases our concern for proven or highly probable syphilis. Scenario 2 is similar. So again, both of the arms of mom's serologic testing are reaction. The treatment is appropriate and there's no concern for relapse or reinfection, but the infant has an RPR or BDRL that's greater than or equal to 4-fold maternal titer. So more of this is on the infant arm. Now, scenario 3 should be mentioned. Again, we don't see it very often, and I think that's because it's often not even thought about. It's more of an epidemiologic concern. We have a mom who had a specific treponemal antibody that was reactive. Then her non-specific treponemal antibodies were non-reactive. So maybe had a treponema pallidum antibody that was reactive. And then an RPR that was non-reactive. And then she had a confirmatory specific treponemal antibody that was non-reactive. But we're in a setting where there is a high epidemiologic concern that mom could potentially have syphilis, and maybe she has early syphilis. So her non-treponemal antibodies are repeated in 2 to 4 weeks, and they are found to be reactive. In that instance, if we have an infant who is similar to scenario 1 with an abnormal examination or abnormal or incomplete evaluation, or reactive non-treponemal titers that are greater than 4-fold moms, then we are in a proven or highly probable congenital syphilis situation. Okay. Don't know why that won't, there we go. So then the next category, possible congenital syphilis. We have 2 scenarios that are very common in this. The first one is, again, maternal specific and non-specific antibody testing is reactive, and we are in that same situation of inadequate treatment or concern for maternal reinfection or relapse, or a partner with a recent syphilis diagnosis. And then the infant examination is normal, eval is normal, and non-specific treponemal antibodies are the same or less than 4-fold. A little less definitive, but certainly still, especially given the maternal status, concerning for possible congenital syphilis. And the scenario 2, again, is similar. This is that epidemiologic scenario where mom had discordant specific and non-specific treponemal antibody testing, but had a high epidemiologic concern for potential syphilis, so had repeat titers performed 2 to 4 weeks later, and they were now found to be reactive. And again, the infant exam and evaluation and RPR or VDRL are all reassuring. Again, that is a possible congenital syphilis situation. And then we have a situation where congenital syphilis is less likely. And this is a situation where mom has reactive antibodies. Treatment is appropriate, no concern for relapse or reinfection, and the infant exam is normal. The non-treponemal antibodies are not 4-fold or greater than maternal titer, and that's a situation where congenital syphilis is less likely. And then the last one, congenital syphilis unlikely. We have a situation where the TPAB or the specific treponemal antibody is reactive. We have non-specific treponemal antibodies that are reactive or non-reactive. But if they are reactive, mom is serofast. So she has a low level RPR that has been maintained throughout the pregnancy, and the infant exam is normal. And in that situation, congenital syphilis is much less likely, so unlikely in that instance. So we get that information, and then we have to figure out how we actually treat our infant based on those scenarios. Excuse me 1 second. So syphilis, or excuse me, penicillin is our treatment of choice. You know, in earlier times, they used things like bismuth and arsenic and horrible things like that to treat syphilis. And so I'm sure that when um, penicillin was discovered and found to be effective for the treatment of syphilis, people were very happy. It's very well tolerated. And we should note, I should note that other treatments really are not recommended. We don't have enough data to confirm efficacy with different treatments. And that includes other penicillin regimens. So, you know, often with our neonates, especially those admitted a little prematurely or with a concern for potential maternal infection, are started on something like ampicillin and gent. Empirically, neither of those would count toward your treatment for syphilis. It's going to be your aqueous penicillin. And so we want to make sure that everybody understands that in some instances, ceftriaxone may be used if you have a shortage of penicillin. And even with that, follow-up is going to be super key and very important for us to ensure the infants have that. So for your treatment categories, with your proven or highly probable congenital syphilis, it's going to be aqueous crystalline penicillin G. And we're going to want to do a 10-day course of that. We can see that the dose is there. You can also use procaine penicillin G given intramuscularly to complete that 10-day course. Possible congenital syphilis is the same. Sometimes, depending on the situation, again, talking about those case-by-case presentations, some providers may use a single intramuscular dose of benzathine penicillin in that situation, but what is preferred is full treatment with aqueous crystalline penicillin or procaine penicillin G. Congenital syphilis, less likely. This is when our our single IM dose of benzathine penicillin comes into play. Sometimes, if the situation is appropriate, some providers may opt out of treating at all. And then congenital syphilis, unlikely. No treatment is required here, but some may give the IM dose of benzathine penicillin G. We tend to generally provide an IM dose of benzathine penicillin G for most of the kiddos who fall into either of these two categories. So once we have completed our treatment, of course, follow-up is super necessary. We want to make sure that the infants are getting excellent physical examinations and histories at their well child visits at 2, 4, 6, and 12 months of age. And again, this is to help us to identify if there is any evidence of syphilis that is ongoing or inappropriately treated. Non-treponemal testing should occur every 2 to 3 months until the test is non-reactive. And that's often helpful because it correlates with the well child visits and makes that a little easier to do. And then the decision to repeat CSF is multifactorial, and generally we would ask that providers call us just to talk through those to determine which of your infants may require a repeat lumbar puncture performed at 6 months of age. Okay, and so we'll wrap up here. Pearls. We tend to be fairly conservative with our treatment for congenital syphilis. Earlier in the presentation, we talked about the facts that what we really want to do is try to prevent the kind of devastating effects, the musculoskeletal and the dental, the neurologic, all of those unfortunate effects of untreated congenital syphilis. That's what we want to do. And penicillin is fairly innocuous and very well tolerated. And so we tend to treat in situations where we don't think follow-up is going to be appropriate, and there is even a small question of what has happened with maternal course. Again, penicillin is going to be your treatment of choice for congenital syphilis, and I will say even for maternal syphilis, so for the maternal infection as well. And I didn't mention in the treatment slide, but it's also important for us to note that if you miss more than 24 hours of treatment for your congenital syphilis treatment course, then that has to be restarted. So you have to restart the course again. So it's really important to make sure you have great access and that you're able to provide your course continuously for your infant. And then, as we talked about, any infant with reactive serology or born to moms who have reactive serology at delivery should have that close follow-up as an outpatient. So they should be shunted into that to the well child check starting at 2 months and the non-treponemal testing at 2 to 3 months. And then any infant with increasing serology titers or persistent or stable serology titers at 6 to 12 months, because we would anticipate that most of them should become non-reactive and have a nice fall over the course of those first 6 months. If they don't demonstrate that after they've been treated, they should be reevaluated, including obtaining a lumbar puncture and retreated. And with that, I will end. Thank you very much.
Thank you, Martha. I'm just going to run through and see if there's any questions for you. Let me see if there's anything else. Everybody's putting their stuff up. You sound so sick. They're all hoping that you feel better.
Oh, thank you so much.
I'm not sure what Lynn means. She goes, what is the time frame if the penicillin doses are missed? What course needs to be repeated? Is it the whole course needs to be repeated?
Yeah, so if
their dose?
Yeah, if you miss more than 24 hours of your penicillin, then you start the 10-day course all over again. So okay. It's 24 hours. And then as far as, oh, I'm sorry, go ahead.
No, go ahead.
And then as far as with this last pearl, if your infant is not demonstrating a decrease in your non-treponemal titers, or you start to see a rise in titers 6 to 12 months after that initial treatment, then the whole evaluation needs to be repeated, and that infant would need to be treated.
Okay. So it's probably best for them to get a central line, something pretty
yes,
guaranteed to be there if they're going to go ahead and do the course.
That's exactly right. And that's what tends to happen with many, at least, of our infants, is that once the our providers know, hey, we're going to treat, then they put in a durable access so we don't have that sort of issue. And I would say the same for, if we're talking about congenital syphilis with a focus really on your newborns, but if you have a situation where you have an infant that comes back and is diagnosed with congenital syphilis, a couple months into life or something like that, sometimes those infants just get peripheral IVs, and we have this issue where the access is lost, and then there's a panic. I would say in those instances, it's best to just bring those kiddos in and put like a PICC in or something like that.
Okay. All right, I have a few more. They're asking, is the resurgence in congenital syphilis throughout the country? And are any states going back to routine screening of pregnant women?
I think it's a great question. Definitely with that CDC information, that epidemiology that I presented earlier in the presentation, that is nationwide that we're seeing. I'm not completely sure what is driving that. I think I don't dabble in the adult syphilis so much, only to kind of know what has happened with mom as far as her treatment is concerned, to help with figuring out what to do with baby. But what we do know is that whenever we see a rise in syphilis in women of childbearing ages, then we can anticipate seeing a rise in cases of congenital syphilis. And so I don't know, I think definitely in states where they're seeing a little more syphilis, they are doing routine scheduling, but screening of pregnant women, but I don't, the CDC still has their recommendations of who should definitely have that. And I don't know that every state does it. It's a great question, though.
Are there any scenarios that warrant longer than 10 days of treatment?
No, not usually. If we don't tend to treat much longer than 10 days. 10 days is good for the neurosyphilis if that's given appropriately as well. So we don't tend to treat longer than 10 days.
Okay. And then there's another really good one here. It says, I'm under the impression that penicillin can only be given IV, but the table is showing IM injections as an option. Would this be an option for babies whose IV access is not only has IV access, or doesn't have IV access and only has 1 to 2 doses left, versus trying to put a new IV in them?
Yeah, and that's a great question, and it's one we kind of run into sometimes, and we take those on a case-by-case basis as well. It's not we don't recommend that, right? Because it's different. It's either all IM or all IV. And so we usually kind of talk through those scenarios, and we try to get our providers not to have issues with that in the beginning by just securing appropriate access to start. If we are going to pursue treatment for congenital syphilis, then we usually just say put in durable access, which is what tends to happen. It's a great question, and we always kind of, we always talk amongst ourselves and try to figure out the best thing to do for the infant based on the scenario.
Right. Can they breastfeed while they're getting treated? If mom is positive and we're treating the baby, can they breastfeed?
Oh, yes. Yeah, there's no issue with breastfeeding, as long as, we didn't mention in here, HIV and syphilis travel together. Mm-hmm. And so we always want to make sure that we know mom's HIV status. So if we don't know mom's HIV status, we may want to hold on breastfeeding until we know that. And then clearly, if mom is HIV positive, then we wouldn't want to breastfeed. But other than that, we could breastfeed.
And is there any one group that we're seeing more syphilis cases in, increased drug users, no prenatal care?
Yeah, that's a great question. I don't know necessarily, we talked about some of the risk factors earlier for congenital syphilis. And certainly when we think about substance abuse and lack of prenatal care and inadequate treatment, those tend to kind of, they often go together, but not necessarily. Not necessarily. I think, go ahead.
Okay. And then I guess our last question is are we providing any sort of education statewide to parents and to women about congenital syphilis and what the signs of it could be? I mean, I remember I haven't even heard really that much about syphilis since I was in nursing school, and that was 30 years ago. And then recently, of course, we're seeing so much more of it. I think a lot of people just have kind of forgotten that it's out there. So is there any thought of maybe giving some good education out there for our families?
I think that's great. I can't say that I know of any sort of kind of like statewide educational thing that's going on. Again, we always get them on the other side, right? So we get the babies once they're here. But I think it's great, and I think it speaks to what am I saying? The slide where we talked about missed opportunities, and that being, we weren't diagnosed appropriately and we weren't getting treatments appropriately. We didn't have good prenatal care. It seems to me like it would be a great opportunity, given some of that backdrop, to develop something where parents know ahead of time, this is kind of what we would anticipate, and saying to moms who are positive for syphilis that this is, the downstream with your baby is an important part of what we're trying to prevent here. Of course, we want to prevent tertiary syphilis in mom, right? So we don't want her to go on to have tertiary syphilis, but also letting them know that there are potential consequences with baby. I think that's great. I don't know that that's being done regularly, but I do think that's a great idea.
One last question about the treatment. It says, would we ever start PENG before the infant's titers are back, or do we need to wait for the titers to be back if we know mom was untreated or had inadequate treatment?
That's an excellent question. And the answer is yes, we would start it before. So there's some instances, right? Like we know, especially in that the scenarios where mom's treatment was inadequate, if mom did not have adequate treatment, we know the infant is gonna need the full workup and need to be treated, because that's definitely a higher likelihood that kiddo would have congenital syphilis. And so it's an excellent question, and one that we tell people, our providers all the time. Hey, if mom was inadequately treated, or you're not going to be able to find and document mom's treatment, even if she says I got treated, you can go ahead and start, because that kid's gonna need it. Excellent question.
Well, Martha, thank you so much for joining us this morning. I hope you feel better.
Thank
your little
you.
rascals, I hope they're doing okay too.
Yes, they are definitely better. So they are better. They get better fast, and I'm hanging on to it. So
okay. Well, thank you. Thank you so much. Feel better.
Of course. Thanks. Bye-bye.